I'm going to be speaking a little bit about neuromodulation therapies for autism spectrum disorder. I don't have any relevant disclosures. I do collaborate with Novo Nordisk on a study of cognition and development in children with hemophilia. And in this talk, I hope to review very briefly the role of device-based therapies for neurobehavioral symptoms in autism, with a focus on a type of neuromodulation called cranial electrotherapy stimulation, which is one that we've used in our practice quite successfully. I just wanted to start out by talking about, what we mean by neurobehavioral symptoms in autism spectrum disorder. And we heard in the previous talk about some really exciting efforts to identify biomarkers that correspond to phenotypes of autism. But for the most part, in clinical practice, even though we do, there are some well-established genetic associations with autism. Clinically speaking, autism is a diagnosis that is based on symptoms, and those symptoms are defined in the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5. And so we consider the core symptoms of autism to be difficulties with social communication and interaction, and a pattern of restricted interests or repetitive behavior. Without those two sort of diagnostic pillars, you can't make the clinical diagnosis. But as many families will tell you, the symptoms that really are most disruptive in everyday life are not those so-called core symptoms. Yes, those are defining features of autism, and they pose significant challenges for kids in everyday functioning. But the really sort of disruptive symptoms from day to day are neurobehavioral symptoms like anxiety, sensory overreactivity, so overresponsivity to sensory stimuli like touch, sound, and so forth. Outbursts, meltdowns, shutdowns, elopements, running away, sometimes without regard for safety, aggressive behavior, self-injurious behaviors, and difficulties with sleep, either difficulties falling asleep or staying asleep or getting up throughout the night. That can be quite disruptive, not only for the child, but for the whole family. And so these are the symptoms that, as clinicians, we're often trying to manage, sometimes in crisis mode. And a lot of one sort of common theme among those sort of disruptive symptoms in autism is that they all are sort of linked to what you might consider a fight or flight response. So and if you think about it from an evolutionary perspective, the fight or flight system is activated in situations in which the nervous system has to be tuned to respond to a threat, either by defending oneself, attacking the aggressor, or running away and trying to escape a threatening situation. Just as in animals who exhibit fight or flight responses in nature, often kids who have ASD and other neurodevelopmental differences appear to be in a chronic sort of fight or flight state, and behaviors can be triggered by relatively minor provoking factors, so that you might see children run away or become aggressive or have outbursts or meltdowns. The fight or flight state physiologically is related to the function of the autonomic nervous system, which is the part of the nervous system that controls our sort of overall level of arousal and immediate response to threat. And the fight or flight response in particular is mediated by the sympathetic branch of the autonomic nervous system. So when the sympathetic branch is activated, we see symptoms of hyperarousal and preparation physiologically to respond to a threat. So the pupils might dilate, the heart beats faster, breathing becomes faster and shallower, the gut slows down, the body shuts down activities that are not essential for the immediate threat response. And there's often a state of hypervigilance, so you're less able to sleep because sleep is a state in which you're quite vulnerable to external threats. The sympathetic branch of the autonomic nervous system runs on the neurotransmitter epinephrine. So epinephrine is sort of the currency of the autonomic nervous system. Many of us are more familiar with the alternative name adrenaline. So that, that's the neurotransmitter that is increased in concentration in times of stress or sympathetic arousal. By contrast, the counterweight or counterbalance to the sympathetic nervous system is the parasympathetic branch of the autonomic nervous system, and that's often referred to as the rest and digest system. So when the parasympathetic system is more active, arousal and anxiety decrease, heart rate slows down, respiration slows down, gut motility increases, and you tend to be sort of more relaxed. Sleep might, be more readily facilitated in that state. And just as the sympathetic branch of the autonomic nervous system has its own sort of neurotransmitter, predominant neurotransmitter, the parasympathetic branch does as well, and that is acetylcholine. So acetylcholine is the sort of characteristic neurotransmitter of the parasympathetic branch of the autonomic nervous system. So in part, the relative levels of activity of these parts of the autonomic system are reflected in levels of circulating epinephrine and acetylcholine. We know that in children who have autism and other neurologic and neurodevelopmental conditions, dysregulation of autonomic arousal is related functionally to impaired performance across a wide range of areas, including social participation, academics, self-esteem, and self-confidence. So that the more perturbed your autonomic balance is, the more you have difficulty across these functions and these aspects of everyday life. And this can be studied by a number of means. Of course, one method that we often use to study these types of symptoms is by symptom questionnaires, so directly asking patients, parents, or caregivers about the prevalence of these symptoms. But the autonomic system is also accessible to sort of direct physiologic measures of biomarkers like electrodermal activity, to the sweat response in the skin, and that's because the eccrine sweat glands are innervated by the sympathetic branch of the autonomic nervous system. Blood pressure, heart rate, pupil dilatation, all of these sort of autonomic gated cardiac and systemic functions are amenable to direct measurement. And here I've sort of illustrated that cat in a hyper aroused state. So you can see the pupils dilated, the ears pushed back, which in cats is a measure of autonomic arousal. He looks quite scared. These measures can be recorded in kids with neurodevelopmental differences, and do seem to correlate with exposure to activities that induce stress or hyperarousal. So this graph is taken from a study that came out of the Starr Institute in Colorado, which used skin sensors measuring electrodermal activity, EDA, in kids in a naturalistic setting who were participating in sensory-based occupational therapy exercises. And this is an example from one child who was undergoing autonomic arousal during various activities. And what you can see here is that electrodermal activity, which is a measure of sympathetic activity, varies quite a bit throughout the course of this occupational therapy session. So so the child is introduced to a ball pit, which is a preferred activity, but in the ball pit there is a cloth or lycra tunnel, which is something that doesn't normally occur in that context. And when the child sees that piece of equipment outside its usual context, they experience an increase in arousal, which to the observer, the occupational therapist, looks like an increase in anxiety and inflexibility. Once they get into the ball pit and lay quietly and kind of enjoy that sensory stimulation, arousal increases. But when they're asked to leave the ball pit and climb onto a swing, which is an activity that's more difficult for that child, arousal increases in anticipation of that activity. So you can see these very marked changes in sympathetic arousal that correlate with, with non-preferred, unexpected, or otherwise sort of challenging activities. And this sort of translates behaviorally into increased anxiety, sometimes opposition, defiance, reluctance to engage in a new activity, and at the extreme end, behaviors like outbursts, meltdowns, and aggression. There is by now a fairly large body of research that suggests that children with autism and other neurodevelopmental conditions have a sort of a chronic imbalance in activation of the parasympathetic relative to the sympathetic branches of the autonomic nervous system. In other words, there seems to be an elevated state of sympathetic arousal and decreased parasympathetic tone. And those have been demonstrated separately in a number of studies. And we have some tools at our disposal clinically that can try to modify or alter the balance in one direction or the other. So as a neurologist, one of the tools that I rely on is pharmacology or medication. And we have at our disposal a reasonable number of pharmacologic means to suppress the activity of the sympathetic nervous system, and including antiadrenergic medications like clonidine and guanfacine, which are alpha adrenergic blockers, and propranolol, which is alpha adrenergic modulators, and propranolol, which is a beta adrenergic blocker. And those can often be effective at reducing anxiety, arousal, and sensory hypersensitivity in our children with autism and related conditions. Unfortunately, we don't really have great pharmacologic measures to affect the parasympathetic branch of the autonomic nervous system. And so, one of the sort of goals, if you if you recognize that parasympathetic activity may be dampened or relatively decreased in autism, we might think that increasing the activity of the parasympathetic nervous system would be therapeutically beneficial. And there are some medications that will increase that sort of branch of the autonomic nervous system, either by directly mimicking the effects of acetylcholine or preventing the breakdown of acetylcholine. So medications like bethanechol and galantamine, both of which have been tried in autism spectrum disorder. Unfortunately, they don't work all that well, either in clinical trials or in clinical experience. So that leads us to one other, potential avenue for modulating the function of the parasympathetic nervous system, which is neuromodulation, or sort of direct stimulation of that branch of the nervous system. Neuromodulation is a form of non-pharmacologic therapy, which essentially is targeted delivery of a stimulus to specific neurologic sites in the body. And so the history of neuromodulation actually is quite long, but dates back at least to the experiments of Volta and Galvani several centuries ago, that demonstrated that you can produce, movement of the muscles by direct electrical stimulation. Of course, this is not what we're talking about today, but essentially the principle is that by applying a form of stimulation such as electric stimulation or magnetic stimulation, you're directly affecting the activity of the nervous system in some way. There are a number of modalities or methods for neuromodulation, and those sort of vary in degree of invasiveness. So many of us are probably familiar with more invasive methods like deep brain stimulation, which is used for Parkinson's disease and some movement disorders, which involves the implantation of electrodes into the basal ganglia or thalamus to sort of directly affect those deep brain structures that are involved in control of movement. Another sort of commonly used, relatively commonly used invasive method for neuromodulation is implanted vagus nerve stimulation for epilepsy. So a vagus stimulator is placed on the vagus nerve, often in the neck, to try to modulate the activity of the vagus nerve, and through its interconnection with cortical systems, that seems to be effective in many cases in suppressing seizures. Now, there are also non-invasive methods of neuromodulation that don't involve surgical implantation of a device. The most famous of those probably is electroconvulsive therapy, which has been around since at least the 1930s, and involves the use of electric current to essentially simulate seizures, and that has been shown to be a quite effective treatment for serious psychiatric conditions like depression and catatonia. Unfortunately, that therapy also, is associated with some risks and side effects. It does typically require anesthesia and has to be done in the hospital setting. So it's not really practical, except in extreme cases like the ones I mentioned. There are a number of other sort of non-invasive methods of neuromodulation, however, that are less difficult to administer practically, not associated with as many side effects, and potentially have therapeutic use in the treatment of autism and other related conditions. And those include transcranial magnetic stimulation, which involves the application of magnetic pulses through the scalp to directly affect underlying brain circuits. Transcranial current stimulation, which are sort of a variety of methods that are used to deliver electrical current to the brain in very small doses, in cranial nerve stimulation, which is in most cases a form of transcranial current stimulation, except that in those cases, we're, instead of sort of targeting cortical structures directly, we're targeting cranial nerve endings that interface with the brain and with other neurologic systems. And so one, obvious target, going back to what I had talked about just previously, is the vagus nerve itself. So that sort of main control mechanism for the parasympathetic branch of the autonomic nervous system. The vagus is the longest nerve in the ANS. The name vagus comes from the Latin term meaning wanderer, because it sort of innervates many organs throughout the body. It is an attractive target because it has a number of effects on autonomic arousal. And there is some research that suggests that vagus modulation can be effective for behavioral symptoms as well as psychological symptoms such as depression. And a lot of that comes from the study of vagus nerve stimulation for epilepsy. So as I mentioned a few moments ago, implanted vagus nerve stimulators are used as a form of therapy for refractory epilepsy. So epilepsy that doesn't respond to trials of medication sometimes will respond to direct stimulation of the vagus nerve to kind of reset those cortical rhythms. And it has been noted in patients who receive VNS, implanted VNS, for epilepsy that other symptoms sometimes improve. So symptoms of depression, for example, have been noted to improve in people who receive VNS for other indications, which in turn has led to studies of implanted VNS for depression. We also know that, of course, there's a high degree of comorbidity between autism and seizures and epilepsy. And so a number of individuals with autism have received VNS for epilepsy. And it turns out that in those individuals, if you sort of look at behavioral effects over time, VNS can improve behavior actually independent of its effects on seizure frequency. Now, it turns out that there are methods to stimulate the vagus nerve transcutaneously. So, apart from implanting a surgical stimulator, you can also activate or stimulate that nerve non-invasively through the branches that come close to the skin. And one of those is the auricular branch, which innervates the ear. There's an illustration here of the kind of the density of vagal innervation to the ear. It's mostly in sort of the inner part of the external ear, so the tragus and the inner part of the concha. And those are relatively accessible to stimulation. So you can place electrodes on those parts of the ear to stimulate the vagus nerve directly. This is just an illustration of a cat that is receiving vagus nerve stimulation. And based on studies that have shown the efficacy of implanted vagus nerve stimulation sort of incidentally for neurobehavioral symptoms in autism, it's been suggested that transcutaneous vagus nerve stimulation might be a promising method for treatment. Unfortunately, there are some practical problems. As a clinician, there are some difficulties with administration of transcutaneous vagus nerve stimulation outside the research setting. One of them is that it can be a little bit difficult with many of our patients who are children, just because the direct afferentation of the vagus nerve is to parts of the ear where it's not that easy to place clips. You do have to also sort of clean those parts of the ear relatively vigorously to remove earwax and things that interfere with electrical conductance. And so the placement and wearing of vagus nerve stimulation equipment is not that readily tolerated by a lot of our children. The other issue from a clinical perspective is that commercial devices for transcutaneous vagal nerve stimulation are not very readily available in the United States. There are commercial devices that are available in Europe, but it's relatively hard to get them here. And so we've looked for alternatives. One of those that we've sort of turned to is cranial electrotherapy stimulation, which is a type of transcranial current stimulation that is a little bit different from vagus nerve stimulation in that it uses proprietary waveforms that may fluctuate over time. So rather than sort of traditional transcranial direct current stimulation, which uses square waves with a certain frequency, CES often uses proprietary waveforms that can be variable. But the basic idea is quite similar in that it sort of passes electrical stimulation through nerve endings that interface with cortical systems. One advantage of CES is that there are commercially available CES devices that have been FDA cleared in the US based on substantial equivalence to older devices that came on the market before the Medical Device Regulation Act of 1976. It's not entirely clear from studies how cranial electrical stimulation is postulated to work, but we do know from neuroimaging and other methods of studying brain activation that CES appears to reduce activation in regions that are associated with hyperarousal and mood. And so in our practice, we've used a device called the AlphaStim Aid Cranial Electrotherapy Simulator. And Interestingly, this device also has clips that are attached to the ear. Now, in this case, instead of being attached to the tragus, they're attached to the earlobes, which is usually much more tolerable and easier in terms of preparation. And there is some vagus nerve afferentation to the earlobe as well, as you can see in this diagram. It's not as dense as the afferentation to the ear canal, but you are getting a bit of vagus nerve stimulation by stimulating the earlobe. And so we think that that's likely to be a potential mechanism of action. And so we've studied this in our practice. We hypothesize that CES should lead to improvement for children that are affected by autonomic gated conditions like sensory overresponsivity, anxiety, sleep disturbance, gastrointestinal disturbance, motor tics, and so forth. And so we've studied actually larger than this number at this point, but at the last reanalysis of data, we looked at about 223 participants who ranged in age from about 2 to about 27 years, who were prescribed CES for one of the indications that I mentioned related to autonomic dysregulation. The participants wore the device at home for 20 minutes a day, 5 to 7 days a week, typically starting at 100 microamperes of stimulation. And we measured response using a survey that was completed by their parents or caregivers. And the results actually were quite encouraging. So if you look at just the prevalence of symptoms, regardless of severity, how many patients had these symptoms before CES and after, what we can see is that there was a fairly substantial reduction in symptoms of anxiety, outburst meltdowns, sensory hyperresponsivity, and other autonomic gated functions after the 4-week trial compared to before. Now, this was not a randomized placebo-controlled trial, but these are patients who often had tried a number of other interventions to very limited effect in the past. And so it was encouraging to us that many of our patients who had not responded to pharmacologic therapies or other therapies did show a really good response to CES. And this is kind of another way of looking at the same data. If you kind of break the responses into 3 categories, those whose symptoms resolved following CES, those whose symptoms were present both before and after CES, and those who developed new symptoms after CES, one can see that in the vast majority of, for the majority of these indications, there was resolution of symptoms in a substantial fraction of patients after CES compared to before. Now, there were some patients who did report new symptoms that weren't there prior to CES, but those were in all categories outweighed by those whose symptoms showed resolution or a significant improvement. I was going to talk about some other modalities of neurostimulation, such as transcranial magnetic stimulation, but I think that time is running short, so I may wrap there. I just to say briefly that we've explored other methods of neuromodulation like transcranial magnetic stimulation, which has been FDA approved for the treatment of depression in adults, but there is both research indicating that the mechanism of action of TMS may be modulated in part by its interaction with frontal vagal networks, so cortical networks involved in the modulation of autonomic function. And there's also some research in children with autism suggesting that both behavioral and autonomic measures improve with the application of TMS. So that's something that we're very interested in as well. And so with that, I'd like to thank the research and clinical team at Cortica, without whom I would not have been able to present any of these findings, and I'm happy to take any questions that you might have.
Thanks, Dr. Shapiro. That was really wonderful. I learned a lot. I'm sure the audience did too. Something you didn't touch on, but I thought might be of interest to the attendees, and you might want to share is, can you just give us a quick sort of executive summary about Cortica? Because you talked to us about the neuromodulation, but tell us, what is Cortica? What do they do?
Yeah, so Cortica is essentially a I always struggle a little bit with how to describe it at a broad level, but we are an organization that essentially is a healthcare home for kids with autism and other neurodevelopmental conditions. So it's anchored in pediatric neurology, neurodevelopmental neurology, but we try to provide all of the sort of therapeutic supports that kids with autism typically need. So our centers include a medical component, neurology, as well as occupational therapy, speech therapy, physical therapy, behavioral therapy, and psychotherapy, what we call family wellness counselors. So we try to take a 360-degree approach to treatment of autism. And part of that, part of what that allows us to do is to study novel therapeutics in a context where we have a good relationship with our patients and the families, and a lot of information about what other, not only what other therapeutics they've tried, but what other sort of therapies they're receiving, both at school and in the clinic.
Wonderful, thanks. So you were talking for some of your presentation about CES. Is that the same as or different than TDCS?
Yeah, it's different. So TDCS and CES are both modalities of transcranial current stimulation. TDCS is transcranial direct current stimulation. So it's in principle rather similar, but a little bit different. And the primary difference between TDCS and CES is it really has to do with the waveform, and also to some extent with the method of application. So TDCS is usually applied by electrodes that are applied to the scalp at different locations. And usually you're trying to affect sort of relatively broad fields within the scalp. There's an anodal and a cathodal electrode in TDCS that sort of serve as the poles for current delivery. Whereas CES, in broad strokes, is a little bit more neutral in terms of how the current is applied. So there are CES devices that are applied to the forehead, but there are also CES devices that are applied to the earlobe. And really the kind of defining feature of CES is the waveform rather than the site of stimulation.
Thank you. An attendee asked, what device was used to measure the electrodermal activity as a proxy for sympathetic activity and arousal levels?
So in that study, as I mentioned, that was a study that came out of the Star Institute in Colorado, and they used, I believe, an ankle bracelet that measured electrodermal activity. I'm not, I don't know the brand or type of the device, but it was a study that was quite unique in many ways. But one of the things that was nice about it was that it looked at a device that was able to measure EDA in kind of a naturalistic setting. So it was an ankle bracelet that that kids could wear while they were doing activities or occupational therapy sessions. The paper just came out in Frontiers in Integrated Neuroscience. So I think that you can find the specific information there, but I'm sorry, I don't recall off the top of my head what type of device it was.
I'm curious, with the devices like that, I mean, do you see that as a component of future clinical trials?
Yeah, I think I do. I think it's important. I really think that autonomic dysfunction is an important clinical indicator of sort of relevant behavioral symptoms in autism. And so I think that incorporating that kind of biomarker in clinical trials would be really relevant to, measurement of effective therapies.
And it's objective.
And it's objective, right?
Yeah. This is related. Has your clinic had experience using TDCS for language? I'm gonna wonder if they may have meant CES and intertwixt the two like I did.
Yeah, so we haven't studied it specifically for language. So TDCS has been studied for language primarily in patients with adult patients with various forms of aphasia, either post-stroke aphasia or primary progressive aphasia. There's a pretty robust literature on use of TDCS for remediation of aphasia in adults. There's not as much literature on use of TDCS for language in kids with developmental language disorders, and we haven't studied it specifically for that. But it is an area that I'm interested in.
And the last question is, can you clarify the sleep results from the CES study? Does new symptoms in that category mean that kids who didn't have sleep issues develop new issues in that area, or could it be something else?
Yeah, so no, so that's right, and that was actually an interesting and not totally expected finding that I didn't get into, but it's true that compared to the other sort of autonomic gated functions, we saw more sort of new sleep symptoms after CS than in those other symptom categories, and what that typically meant was that sleep patterns were changed by CES in a way that was not perceived as therapeutically beneficial. So the main goal essentially was for kids who had sleep disruption to use CES to help with falling asleep or staying asleep, and it did seem to be effective for that. But in some kids, what we saw was more daytime sleepiness, which was not, necessarily a desirable effect.